I have been here all day. There's always more that I can learn. So I'm a learned experience in breast cancer, not a lived. So sometimes I actually feel quite isolated treating breast cancer patients because a lot of therapists in this area become therapists in lymphedema because they have it. And I am not one of those. So sometimes I feel like I'm actually the odd one out rather than the normal. So that throws me into a little bit of a... When you talk about being isolated, I actually understand how that feels. I'm just on the flip side. So my history is I'm a musculoskeletal physio. I actually have a master's in sports physiotherapy, and that's where I started. And then about 8 to 9 years ago, my name was on an interest list for lymphedema. So all of a sudden I started getting sent lymphedema and clotting patients, and I was like, well, maybe I should actually learn something about this area. So I dug myself down a rabbit hole and have continued to dig myself down that rabbit hole for 8 years. Dr. Redfern commented on the number of published papers in early breast cancer I was in, and he said there's one every 11 minutes. That makes me feel much better because I definitely don't know everything and I can never seem to keep up. So I actually think the people that teach me the most are my patients. So this is from the Australasian Lymphology Association. All persons undergoing treatment for breast cancer should be made aware of their risks of lymphedema and be provided with evidence-based practice, risk reduction education and guidelines and local lymphedema services information, and this information should also be available at subsequent reviews. And I bet if I asked you to put your hands up in this room, less than 20% would tell me that you were actually told about the risk of lymphedema at diagnosis. Because most of you are, but when you've just been told you have cancer, pretty sure lymphedema is right down here on the list. So even if you are told, it won't register. So most of the time it's not a thing unless you have a family member with it and are terrified of getting it, or if you start to get symptoms. So it is completely normal, and a lot of the research in the area is showing that early monitoring and early regular reviews and things are the best practice, but in reality, I can tell you as a clinician, it doesn't happen. And as much as we try to make it happen, I know Michelle from breast care nurse and myself are two of many that try and make it happen, but I'm also very aware that it's not a reality. So don't feel bad if you think, oh, no one's ever told me this. It's completely normal. So what is lymphedema? Lymphedema is a condition where an accumulation of excess amount of protein-rich fluid results in swelling in one or more regions of the body. Now in this room, breast cancer, everyone will be thinking arm, but I actually treat a lot of breast and chest wall lymphedema. So don't forget those areas are actually involved as well and a big part of your journey. Lymphedema is due to a failure of the lymphatic system and occurs when the demands of the lymphatic drainage exceed the capacity of lymphatic circulation. And in breast cancer reasons, that is because your lymphatic structures have been changed with surgery, radiation or chemotherapy. So people can actually be born with lymphedema that can develop over time. That's primary lymphedema. Breast cancer fits in the secondary lymphedema category. In breast cancer, it's usually due to the things I just said. Look, I'm ahead of myself. So risk factors for developing lymphedema. So 20% of all breast cancer patients are at risk. Your extent of surgery and location will impact that, and the number of lymph nodes removed. Radiation, the extent and location. If most people have radiation to the front of their chest, but if you have axilla or neck radiation as well, which can happen, that increases your risk dramatically. Infections post-surgery put more load on your lymphatic system, so therefore you've had a greater chance of lymphedema down the track as well. Increased body mass index, so being overweight, unfortunately, which, way, you've had enough to deal with, now you've got to not be fat as well. Joy. And immobility, which is definitely one we can all change, which I know people have spoken about exercise, and the second part of my talk is actually on PINK, which is recovery and exercise through your cancer journey, and it will also have an impact on lymphedema. So early signs of lymphedema, which I guess even in the room, if you don't already have it, these are the things that you need to be aware of. These can start out as intermittent, so you might think that one day it looks a bit swollen and then the next day go, oh no, it's not, and then it comes up again. Go and have it checked is the short answer. Always just go and have it checked. My business cards are in the thing. I'm always happy if someone wants to just send me an email. I will try and get to it. I can't always answer the question via email. Sometimes I actually need to physically see you, but I will try. And I will either say to you, no, that's fine, give it another week or two, or no, please come in and see me. I'm more than happy to have a look and see what we can do. Reoccurring cellulitis. So cellulitis is actually an infection in the fluid, and it causes a red, hot swelling. Lots of people actually end up in hospital on IV antibiotics with cellulitis. It's a really big concern, and the more repeats of this that you have, the greater chance of long-term lymphedema you get. Feeling of aching, heaviness or stiffness in the body part, and this is often the first sign. People often don't see a change in their limb, they often feel it, and the number one thing people come to me and go, oh, my arm just feels really heavy, do I have lymphedema? And I say, I don't know, but probably. So let's treat you as if you do, rather than let's wait and find out. Decreased range of motion that affects the body part, and tightness of the affected body part, so you'll notice clothes and jewellery may feel tight and not fit as well. Conservative management of lymphedema. I have only mentioned conservative management, but anyone's welcome to ask a question whenever, and there are new research being done in surgical managements, and so I'm happy to touch on those a little bit. I don't know that much about them, but they are in the early stages. But compression bandaging is used for limb volume reduction. This is if you have a sudden massive flare or with cellulitis and your limb is completely out of control. We will bandage regularly to try and get it down. I don't do a lot of it because it actually requires daily treatment, and I am a private clinician, so that's really expensive. So we do try and find other options for you, and often you'll have bandaging done if you go into hospital with cellulitis. Compression garments prevent and treat. I measure and fit for all garments, and I do this a lot, and this is probably our number one management strategy. Anyone who has had breast cancer and is travelling should have a sleeve, whether you want one or not, I'm sorry to say. Manual lymphatic drainage and self-massage can be used. I'm trained in the VODA technique of MLD. There are multiple. I have also recently done the Macquarie University advanced alert course, and they do a functional MLD, so I actually do two types that I kind of mix together and make up my own. But manual lymphatic drainage is the idea that we stimulate your lymphatic system to try and help the pathways that are still there work to their optimal efficiency. Skincare is probably the biggest one that you can all do on a daily basis. So skincare is really important because if your lymphatics aren't working as well, you generally do have a slightly higher protein rich, and it will dry your skin out. So that's why they talk about moisturising a lot. And if you keep it moisturised, it's less likely to crack and break down, less likely to cause an introduction of an infection, and less likely to cause cellulitis. So I actually would say the number one thing that you can do from day one is skincare. Exercise, including deep breathing exercises, which was my prompt to do the Neil Pillar breathing exercises, but we've already done them today. But what we know about deep breathing is it stimulates your diaphragm, which is actually right next to your deep lymphatics, which is why it helps. So when you do deep breathing and move your arms around, it helps stimulate the pump in the deep lymphatic system, which helps process lymphatics around your body. Pumps are, so intermittent pneumatic compression pumps are now becoming quite available. They're still quite expensive to purchase privately, but you can hire them from some places, and they essentially work like an MLD pattern, but from the outside. So for arms, you slip it on, it's an arm, and you can have a chest piece, and you turn it on, and you sit there for 20 minutes, and it pumps you like a manual lymphatic drainage. There is becoming more research on them being quite positive, and they're used a lot pre and post-operatively for liposuction and things like that. So they do have a place, and I do recommend to people that if they want to go down that avenue to look into hiring and trying them. I think it's a very personal choice, and you have to find, one of the things my patients that do have them find annoying is they have to sit there for an hour a day with it on, doing nothing. So it is quite time consuming. So low level laser therapy, I do some of this in my office. Most of this I use for scarring, cording, seromas, and so mastectomy recovery a lot, any kind of scarring, DIE, P-flap, recovery. The research about this is really interesting because they know that it works, but for a long time they didn't know why. I just did a bit more research this week. They actually think the photophonic energy in it has a cellular level change in cells, which is why it helps with scarring. And the good thing about it is we know that it can't do you any harm. It's low level, there's no heat involved, there's no cell damage involved. So it's a pretty great tool. There's some evidence of it coming out in actually helping with lymphedema as well. It's in the early stages. Neil Pillar's actually doing some research in that area, which is quite exciting, and it gets used quite regularly. Prospective surveillance and early intervention, which is probably the biggest area, and the Macquarie University Alert program is doing a huge amount in this study, which we're now finding that if you have regular tape measures and SOZO or bioimpedance spectrometry measures, that you're having a better chance of us picking up lymphedema subclinically, so before you can see it. And they're even showing some signs that if we get you into compression at that point really early for 2 weeks, good management, we can actually reverse lymphedema, which is super exciting in this space because previously lymphedema was not curable, and it is not curable, but we're finding that we can get it from subclinical to 0 or even class 1, grade 1 to 0. Once we get past class 1, we're really in a management strategy point of view. So a prospective surveillance and early intervention model of care for lymphedema can be defined as a proactive means of providing patient care whereby the practitioner aims to detect lymphedema before clinical signs of swelling appears and to manage other sequelae related to cancer treatment. So this is what I was just saying. So we take lymph volume measures of the tape measure and the bioimpedance spectrometry, which measures the total limb volume of extracellular fluid in the limb. And then we can monitor that over time, and we know that a change of a certain amount means you're heading towards lymphedema, and we can try and get it before it's bad. Looking at range of motion, activity limitations, pain, fatigue, and function. So we look at all of these things, and all of these things are really important. I think one of the biggest things I find with my breast cancer patients is they just think that pain and immobility is normal. It is not. You should be able to get everything back as best as we can. Every now and then there are some limitations depending on the severity of your treatment, but we can always, and as a physio, I always aim for more. There's always more. So the only time I stop treatment with my patients is when they're happy with whatever they've got, because I'm never happy. So recommendations, 3 monthly monitoring for the first 24 months post-diagnosis. There is some research that that's even up to 5 years rather than just 2. And it's best to have a preoperative measure if possible. I know a lot of the time that's unlikely. Most of the time from diagnosis to surgery is often less than a week, so you don't really have much time in there to get that happening. And rehabilitation and exercises, this is at all stages of treatment, recover and adapted to any impairments and restrictions. So I think this is the most important thing, that people tend to not want to exercise. In your little pamphlets, I've given you 2 lots of exercises. One I've written as cording, but it's for anything post-operatively. So we're all going to grab a piece of band and stand up. And you're going to put one end of your band under your one foot and hold it with the same hand. Oh, we're just missing a pack. Ah, there we go. Yep. So you should have your band under one foot and holding on in the same hand. Don't let go, it will flick. And you're going to push. Your goal is to push towards the roof. Obviously, you only go as far as your arm will allow you to go, and coming back down. It's things as simple as this that will help with cording, mastectomy scarring, and improving lymphatic flow in your arm. So as you can see, it doesn't have to be a complicated exercise program. You just want to be moving. Good. Just make sure you don't flick yourself when you take it out from under your foot. And I think, does anyone have any questions about lymphedema?
With that exercise, when would you start that?
As soon as the wound is healed.
So maybe 3 weeks, 6 weeks?
Depends. Some people are healed at 3 days, some people it takes 10. Pretty much move as soon as you can. The only other proviso I give on that is if surgeons give you an order not to lift your arm above shoulder height for 2 weeks, do not do it, because I don't want to be in trouble. Surgeons are at the top of the food chain and I don't mess with them. All right. But other than that, as soon as you feel comfortable. Yeah.
I missed what you said. Is it likely to be anywhere other than the arm?
Could be chest wall or breast if you've still got a breast. Yeah. Yeah, but chest, yeah. So the lymphatic flow for your arm, the way your lymphatics flow, so if it's a left arm, it's actually anything above your belly button, anything to the left of your midline, and anything below your collarbone. So when you've had lymph nodes removed from an axilla, either side, it's that whole area that's actually at risk of lymphedema. We tend to find hands and arms are worse because of gravity and distance of flow, but it isn't the only place. And some people will have nodes taken up in their neck as well. That actually means your face and neck are at risk as well. So I guess that's one of the things that isn't very well explained. It can even be the back.
Is it still beneficial 8 years later?
Absolutely.
Exercising?
Absolutely. So risk of lymphedema is until the day you die, unfortunately. So I have women come to me and go, I had breast cancer 20 years ago and now I'm getting lymphedema. And I'm like, yeah, well, unfortunately, what they think in research is that it is at that point that your lymphatic system has stopped being able to cope. We don't know why all of a sudden, but as time goes by, there's at some point that whatever damage was done or changes were done to your lymphatic system during your cancer treatment, it's that point that it's finally stopped coping. Yep. So unfortunately at any time, which is why I said anyone's recommended to actually have a sleeve or compression garment for flying. We know that flying, any travel over 2 hours actually, so if you're planning to drive around Australia, it implies as well, but flying because of the pressure changes is a much higher risk, and it's often the day after you fly, not actually the day before.
So how long would you wear that garment for?
So the recommendation is while you're flying or travelling, but I personally recommend the day after as well. Yeah, if you can tolerate it. If you're going to somewhere really hot, and a lot of people ask me when they go to Bali, if you're going to spend the next day in the pool, hydrostatic pressure is almost as good as a garment. So as long as your arm's in the pool too, go for it. Yeah. So if you're going somewhere hot and you don't want to wear your garment the next day, spend the day in the pool. Because hydrostatic pressure or water-based activity is excellent for lymphedema. Yes?
Do you have to have proper garment, or can you just wear one of those stretchy things?
No, so Tubi grip in particular, which is isn't graded compression. So it's got the same amount of pressure here as here. So it actually has a much bigger risk of pushing swelling into your hand. The proper garments are actually designed to have the most pressure here and slowly grade up, so it will move fluid up. And this is one of the things, because when we say don't wear tight clothing because it'll cut you off, and then I come and put you in a compression garment, you're like, how does that work? But it's because it's actually graded. So it should be, and the recommendation is that you actually have a hand piece as well as an arm piece, because if we put you in a sleeve, it can make your hand swell as well. If you're not travelling overseas, I say to my patients, my personal recommendations are we fit you with a sleeve, and if you have any trouble, then we add a handpiece. I just had a patient the other day, she's 10 years post, about to go to Italy. I was like, no, we're having both, because if you get to Italy and don't have a handpiece, then we're in serious trouble. So I will always fit people with a hand and a sleeve if they're heading off to the other side of the world, because we don't know what their arm's going to do.
So the two pieces, two garments.
You can have it as two or you can have it as one, but most people prefer it as two because it means you can take your handpiece off and wash your hands and do your thing. And the garments have moved a long way even in the last 5 years of me working, and they've all got moisture wicking technology in it. They're quite cooling, they dry really quickly, and there's so many options to try and find something that you will be happy to wear. Because number one thing with garments is compliance of wearing. I get that, who wants to wear a garment all the time, but a lot of the technology now is pretty good. They're actually pretty comfy, and a lot of my patients now say they forget they've got them on. So yeah. The night ones? I'm a huge fan of the night garments. I can tell you if it was me diagnosed tomorrow, I'd go with the night garment first and try and get away without a day garment. The research still shows 12 hours day wear is recommended, but I say to patients, whatever's going to make you wear your garment.
I actually
Sorry, I actually find the night garment actually leaves a lot of pressure marks, and even though it's much softer
Yeah.
than the one that I actually have on today.
Yeah. So it depends on the...
I love my night one.
Yep.
I don't know that it's on until I actually take it on the next morning, and I've got these little railway tracks up my arm.
Yeah, so do you have a Hat and Hands comfy wave then with the nice convolutions straight up?
Yeah,
blue
yeah.
and white one?
Oh, I can't remember whether it's blue
Yeah.
and white or
They're
it's blue and
great.
black.
They're new on the... Well,
White
I
and
shouldn't say
black?
new on the market.
White and black? I don't know, I can't recall.
Yeah. But no, the night garments are quite pleasant because they're actually a lower grade of compression, and so they're much more comfortable. They're bulkier usually. They're usually quite bulky. But yeah, that is an option. So, and I do say, although the research is recommending 12 hours of day wear, I say to people, if you don't want to wear a day garment, let's start with a night one. So, yeah.
Pia, how often should people get their garment changed? Like, how would they know that they need a new one and the old one's not really doing the trick anymore?
Most of my regular patients, the ones that are wearing them daily, no. They actually get loose and fall off. But the shelf life is 6 to 12 months. Yeah. So, of the elasticity in them. So they start to lose their compression value. And 6 to 12 months is quite a long time, but once you're wearing them a lot, we need to find that out. I'm just going to move on to the pink bit because we're running out of time, and then you can ask me more questions at the end. So I'm also a pink and steel cancer rehab provider. And that is purely exercise through cancer. For pink is for women and steel is for men. So we're mostly talking about pink today. And the idea is, I find this kind of hard to describe because people often come in and want to do pink, but it's like it's not a thing. It's that I'm there as your liaison to get you moving however you want to or need to get moving. So I think that's the big tip. So medical treatment saves lives, but cancer rehab gives you back your life. So most people, and it's been spoken about a lot today, that you're often left hanging at the end of your treatment. And although pink can be done during treatment as well, our job is to try and get you back to whatever you want to do after you've gone through cancer treatment or are going through cancer. Being disease-free does not necessarily mean that you are free of your disease. And I think this is one of their best slogans. Pink is actually very good at slogans. If you have a look at their website, they're full of slogans. But this is one of their best ones because it's all about making you happy with the life that you're living after you have had treatment or while you're having treatment. So without rehabilitation supports, people can experience unnecessary disabilities and suffering, poor health and deconditioning, no energy, pain, depression and increased anxiety, which spoke about earlier, and trouble returning to work and doing things they love. Early proactive referrals can improve outcomes and reduce suffering. Reasons for referral is pretty much anything that you don't like that's going on. So reduced mobility, balance, potential post-op complications, deconditioning, lack of energy, pain, numbness. Chemo-induced neuropathy is a big one. There's actually quite a lot of research in the space of exercise for chemo-induced neuropathy, and it's actually doing quite well. So although we all want a tablet or something to do, the best thing to do is get moving. So yeah, joint stiffness, reduced function, return to work, chemo-induced neuropathy, lymphedema, bladder and bowel issues. That's where pelvic health physios come in. I am not one of those, but I'm happy to refer you to one if you need help with that, and inactivity. So I think the most important thing is the invisible load, which everyone's spoken about a bit today. This lady, I cannot remember her name, but she's actually a model, but she's been through breast cancer, and if you actually look at her undressed, you see there's quite a lot of scarring involved. So on the outside, she looks amazing. But if you think about what she's actually struggling through, there's a lot going on. And I think this is the most important thing, and probably more, this room knows more than any, that's very realistic. So when can rehab be done? Anytime. So it can be done during your surgery or during your treatment. It can be done during your survivorship phase, or it can be done in your prehab phase before surgery. So they've done 900 randomised controlled trials on exercise showing the clear benefits, and it shows that 1 in 3 to 2 in 3 of people living with or beyond cancer are completely inactive, which is a pretty poor statistic, because they've actually also shown that in research it's the #1 treatment for chemo-induced brain fog, chemo-induced peripheral neuropathy, fatigue and lack of energy, And they've actually now researching that they found it actually improves your processing of chemotherapy. There's an amazing study being done where they're actually getting women while they're having chemotherapy to cycle on an exercise bike. And they're showing that they're having better results from the chemotherapy. So I think the number one thing I can say is exercise. So yeah, I've kind of gone through that. Cancer survivors have an increase in cardiovascular disease, high blood pressure, diabetes, osteoporosis, and a functional decline. So unfortunately, having had cancer and having had cancer treatment, you're at higher risk of everything. Just one more thing to add to your fun collection of having had cancer. Yeah, also now all of these. But all of these can be helped with physical activity. So we support with any type of cancer, so not just breast cancer, and during any stage of cancer. And we do, so in the PINK program, they also do, the process is, I'm not a paddle on, but they do a lot of sup work in areas around New Zealand and Australia. But in our clinic, I do individual work, and I will lead you into our group rehab classes within our clinic. They're not specifically cancer-based only, but they're still group rehab. Kind of spoken about that. I think that is it.